Okay, well, I think we'll make a start. There'll be some other people joining as we go, but we've got a bit to get through today. So good day, everyone, and welcome to paediatric teaching for this week. I wanted to talk about neonatology for the next few weeks. And the first topic I wanted to cover was the basics of very low birth weight babies and prematurity, because that's perhaps the most important. Having an understanding of how to care for very low birth weight babies is really important for paediatricians, and so I wanted to talk about the basics of those things today for all the trainees. So today we're going to talk about very low birth weight babies and preterm babies and the complications they have and how to look after them. I guess first of all, just to say that low birth weight is really common, and I'm sure you know that, but about somewhere between 15 and 24% of all babies have low birth weight. It's more common in some countries. Certainly it's more common in Papua New Guinea than it is in other countries. But yeah, 15 to 24% of all babies have low birth weight, and up to 18% are preterm. So somewhere between 6.6 and 18% are preterm. And the variation is between hospital settings and community settings. When babies are born in hospitals, they often have higher rates of prematurity and low birth weight only because they're more likely to be referred if the mother's at high risk, so therefore more likely to have a low birth weight or preterm baby. So both very low birth weight and preterm prematurity are really common, and again, as paediatricians, we need to be experts in the management of this sort of thing. Just to get to some definitions, it's important that we understand the definitions of what low birth weight and very low birth weight and extremely low birth weight are. And these are the World Health Organization definitions. So a low birth weight baby is less than 2.5 kilos or 2,500 grams. A very low birth weight baby is somewhere between 1,000 and 1,499 grams, so just under 1.5 kilos. And an extremely low birth weight baby is a baby that's born less than 1 kilogram or less than 1,000 grams. We classify prematurity as anything less than 36 completed weeks of gestation, and then you can break it up into late preterm, which is between 34 and 37 weeks, and early preterm, which is less than 34 weeks. So it's useful to have these standard definitions when we're referring to babies as to whether they're just preterm or whether they're preterm and low birth weight. And then we have the classification of small for gestational age, and that can apply to babies that are either term or preterm. And that's the definition is any baby below the 10th centile for their gestational age. And what I've put on the right side of this slide is a graph that shows the weight according to gestational age. And you can see that this is the birth weight according to gestational age. It's not a growth chart as the child grows, but it's the birth weight according to gestational age. So you can see that a baby that's born at 36 weeks should have a weight that's close to, this is the appropriate weight for gestational age, these two lines here. And so a baby born at 36 weeks should have a weight that's somewhere around about 1,800 grams, all right, just less than 2 kilos. That's the minimum weight for 36 weeks gestational age. And the maximum weight for gestational age of 36 weeks is somewhere between about 3.3 kilos up here. But so if you had a baby that was born at 36 weeks and was only 1,400 grams, then not only are they early preterm, they're late preterm, they're somewhere between 34 and 37 weeks, so they're 36 weeks. They're not only late preterm, but they're also small for gestational age. So to be able to classify babies into whether they're preterm, and if they're preterm, whether they're late preterm or early preterm, and if they're preterm, whether they're normal for gestational age or small for gestational age, becomes quite important in understanding the complications that can occur in such babies. So I hope that makes sense. It's useful to have this graph so that you can classify babies according to this classification. Now the question then is how to assess maturity and how to assess the degree of prematurity. And there's a number of different scores that you can use to do this. I'm going to talk about the 2 clinical scores. There's lots of different ways, other ways to do it, like ultrasound assessment, but I'll talk about the 2 clinical scores, and I'll primarily talk about the second one, the Ballard score. The Dubowitz score was the first score that was developed, and then that's been largely superseded by the Ballard score, which is probably a more accurate score. The Dubowitz score was first developed in 1971, and it was primarily based on the idea that preterm babies are more hypotonic than term babies. So I'm sure you've all seen a preterm baby that has no tone, their limbs are outstretched, they don't have a flexed posture, and the whole of the Dubowitz score was largely based on these external neurological criteria that looked at the muscle tone of the baby. It also, preterm babies are more hypotonic and they have less flexion, and term babies have more tone, they have more flexion, they have more elastic recoil, which means when you take their arm, which is in a flexed position, and you extend it out, then it's more likely to flex back, the elastic recoil of the limbs. And they have more resistance to extension. So a term baby, a preterm baby, if you hold that preterm baby in ventral suspension, then they'll just be floppy. They won't have any tone at all. Whereas a term baby will have not so much head control, but they'll have a straighter back. All right. Whereas a preterm baby will just be floppy. A preterm baby that you pull to a sitting position will just have complete head lag, whereas a term baby won't have complete head lag. And so that's the principle of the Dubowitz score. It looks at a variety of different gross motor motor functions, like their posture, this thing called the square window, which is the angle of the wrist, the ankle dorsiflexion, the arm recoil, the leg recoil, the popliteal angle, which is a bit like the dorsiflexion of the wrist, but just at the popliteus at the knee, so as to whether or not the leg can be fully straightened out, or whether it's held in a flexed position. Then the heel to ear, which is a very preterm baby, you can take the heel and put it close to the ear. Then there's the scarf sign, where you move the baby's arm across the chest, and whether it's all to do with the amount of elastic recoil and the tone that they have in the limbs. Then head lag, as I mentioned, and ventral suspension. Now, as well as that, later on, the Dubowitz score added some what's called external criteria, and they're similar to what you measure when you're doing a Ballard score. It's based on the principle that a preterm baby has immature skin and cartilage, and so the ears will be more floppy, the nipples will be less formed, the eyes will be more closed, there won't be palmar or plantar creases, the genitalia will be less formed, etc. So the Dubowitz score was the first one that combined both neurological criteria and external criteria to assess a baby's gestational age. And then the Ballard score was developed, and it was said to be a bit better, but it's largely based on the same principles of having neuromuscular maturity, so criteria for neuromuscular maturity. And I think the diagrams in the Ballard score are very good. They can help us classify the level of maturity of each of the activities, and then the physical maturity or the external features, like in the Dubowitz score, which looks at the skin, looks at the lanugo, which is the fine downy hair that a term baby will have, and a preterm baby doesn't have, and then a post-dates baby loses that fine downy hair. The plantar surface, which is whether or not the skin creases in the plantar surface of the feet, the breast itself, whether or not there's any breast bud development, the eyes and the ears as to whether or not there's any cartilage, the genitalia, a male and a female. So when you're doing the Ballard score, you can look at all of these areas, and the score tells you whether or not the baby is preterm or term or post states. So just to reiterate again, the neurology tests the muscular tone of the baby. So what the posture of the baby's like, how the baby holds their arms and legs, this square window, how far the baby's hands can be flexed towards the wrist, the elastic recoil of the arms and the legs when your baby is pulled to ventral suspension and to a sitting position. Then the popliteal angle, the scarf sign, and the heel to ear sign. So they're the neurological features of the Ballard score. And then the external features are the skin texture, that is whether it's sticky, like a preterm baby has quite sticky skin, and a term baby has smooth skin, and then a post-dates baby has peeling skin. This lanugo, which is the soft downy hair that a baby has that preterm babies don't have, term babies do have, and then disappears in post-maturity, and you often get peeling skin. The plantar creases, the breast bud, the eyes and ears, the male genitalia, whether or not the skin creases in the scrotum or not, and the female genitalia, the relative prominence of the clitoris and the labia, which is more prominent in very preterm babies. So from that, you can work out the degree of immaturity of the baby. So I wanted to talk about complications of prematurity, and I think it's useful to think about when we're looking after a very low birth weight or a preterm baby, it's useful to think about all the different complications they can have. And I think about it in a systems way. So if you think about what complications can occur in the lungs, in the heart, in the gastrointestinal tract, in the brain, in the skin, in the liver, in the kidneys, etc. So I think it's useful to think about the complications in that way. And whenever you're doing a ward round or examining a very low birth weight baby who might be in the special care nursery, then you should be thinking about all of these different complications that a baby could have. It doesn't mean they will have. Most preterm babies don't have these complications, but you can think about it in these terms. So, for example, we'll go from head to toe, if you like, and babies who are preterm can have intraventricular hemorrhages, which is because of the very friable blood vessels in the blood vessels surrounding the lateral ventricles. They can have intraventricular hemorrhages, and from that they can have, if they have an intraventricular hemorrhages, they can have a parenchymal hemorrhage, like into the brain, and that can develop into what's called leukomalacia, which is just a softening of the substance of the brain where there's been a hemorrhage. They can have retinopathy of prematurity if they're exposed to too much oxygen or if they're very preterm babies. They can obviously have some complications of their lungs, like respiratory distress syndrome, what used to be called hyaline membrane disease. They can have complications in their heart, particularly a patent ductus arteriosus, which is the connection between the aorta and the pulmonary artery, which can lead to heart failure and other complications in preterm babies. They often have gastrointestinal complications, so they can have feed intolerance, or at the most extreme, they can have necrotizing enterocolitis. They can have inguinal hernias, particularly, obviously boys can have inguinal hernias or hydroceles. They can have chronic lung disease, bronchopulmonary dysplasia, cystic chronic lung disease. They can have bony problems like osteopenia of prematurity, where the bone mineralization is not as strong, where there's reduced bone mass, and that can impair growth. So that's sometimes why very preterm babies have, not only do they have poor catch-up growth, but they're of shorter stature later on in life. And that can be caused by lots of different things, the prematurity itself, and sometimes the use of steroids and diuretics and vitamin D deficiency. So they're all important for bone health. Preterm babies have immature kidneys, so they can't handle a solute load, so they can't have too much sodium, particularly in the first week of life. It's very important. Unlike term babies, their kidneys are a bit immature. And then they can have systemic complications like anemia or hypothermia or hypoglycemia, and later on they can get developmental delay, obviously if they have interventricular hemorrhages or other CNS problems. But if you think about all the different organ system complications that preterm babies have, then when we're assessing them, we can be identifying and diagnosing these complications. The care of the low birth weight baby is partly trying to identify these complications, but partly it's also about just doing basic things really well. And all preterm babies need to be kept warm. If they get cold, then they use up too much energy. They're using up their very low stores of energy. And if they get too hot, then their metabolic rate increases as well. And they'll also use up energy to cool down. So they should be kept in what's called a neutral thermal environment, somewhere between 36 and 37 degrees. It doesn't mean the environmental temperature needs to be 36 or 37 degrees, but the baby itself needs to be 36 or 37 degrees. Many of them need oxygen because they've got lung problems, but it's really important that we target oxygen saturations that are not too high. So somewhere between 88% saturation and 95% is safe. And it's been shown that if you target saturations more than 95, they're more likely to get retinopathy of prematurity. And if you go to saturations that are less than 88, then they're more likely to have other complications like interventricular hemorrhages. So definitely not higher than 95. And that's where all very low birth weight babies and extremely preterm babies, we need to have not continuous oximetry, but certainly regular, frequent oximetry, especially if the baby's receiving oxygen. They all need feeding, and breast milk feeding is the best feeding for preterm babies, including colostrum. So sometimes it's been thought that colostrum is not good for preterm babies, but it's certainly healthy. It contains a lot of immunoglobulins and other nutrients that the baby needs. So feed the baby colostrum. And if the baby isn't sucking, then feed down a nasogastric tube if the baby's not sucking. Many extremely low birth weight or very low birth weight babies in the first day or two of life need some intravenous fluids, but we really need to restrict the volume that these children are having to, in the first day, no more than 60 mils per kilo per day on the first day of life. If you give more than that, they're more likely to get a patent ductus arteriosus that remains open, and more likely to get worsening lung disease and to get edema. Typically, these babies are prone to, very low birth weight babies are prone to apnea, and so using aminophylline or caffeine can be useful in the prevention and treatment of apnea. Many preterm babies are at risk of infection, either because they've been born preterm because the mother has an infection, or there's been chorioamnionitis, or there's been prolonged ruptured membranes, and they may be at risk of infection. So I mostly give antibiotics to very low birth weight babies if there's any signs of infection, and until the baby's well for the first 48 hours, and until cultures are negative. If you can take blood cultures, that's ideal, and stop the antibiotics after 48 hours if the cultures are negative. If they're jaundiced, then early phototherapy is important because otherwise they may get kernicterus. And then basic vaccines and vitamin K are very important for these babies and cord care. So care of the low birth weight baby is partly basic, early, essential newborn care, and also the identification of these more complex organ system problems that these babies have, and they're dealing with those problems when you need to. I'm just going to talk about 4 different cases now, and I want you to try to remember the cases. There are 4 cases of babies, neonates who've got respiratory distress, and I want to try to introduce the idea of an extended matching question where I'll give a scenario and then you try to identify what the diagnosis is. So these are 2 x-rays taken several hours apart, but this was a 1.2 kilo baby born by normal vaginal delivery. This was an x-ray done at birth. In the first hour of life, they developed tachypnea and grunting and had an oxygen saturation of 82. There was no prolonged ruptured membranes. There was no maternal fever. And this was the x-ray of the baby at 12 hours of age, so at birth and at 12 hours of age. So you might know the diagnosis of this or the likely diagnosis, but let's look at the second case. Case B. B is a term baby born at 3.4 kilos at 1 week post-term by cesarean section. In the first hour developed tachypnea and an oxygen saturation of 88%. There was no prolonged ruptured membranes, no maternal fever, and that resolved within 24 hours. This baby was born by cesarean section. You can see that there are some similarities in the chest x-ray of the previous baby, although the changes are not as severe, and it resolved within 24 hours. The third baby is a 2.1 kilo baby born by normal vaginal delivery. So this is a low birth weight baby, but not a very low birth weight baby. This baby was born after prolonged ruptured membranes of 36 hours, a maternal fever, the liquor was discolored, the baby was grunting and tachypneic at 6 hours of age, and the baby's temperature was 38.2. So we've got so far three different types of respiratory distress in neonates. And the last baby, a 2.6 kilo baby born by cesarean section for fetal distress. The baby was floppy at birth and covered in thick meconium, was tachypnea and grunting, was hyperinflated and had chest crackles. So we've got 4 different cases of respiratory distress in neonates, and I want you to try to diagnose each one of those. So question A was a 3.4 kilo baby, 1 week. Oh, that's not right. Yeah, a 3.4 kilo baby, 1 week post-term, born by cesarean section. It developed tachypnea. What did this baby, this term baby or post-term baby, most likely have? The baby was born by cesarean section, and that resolved in 24 hours. What do you think this baby had?
Baby has TTN?
Yes, most likely, that's right. Most likely this baby has transient tachypnea of the newborn. The clues are that the baby was born by cesarean section and was a term baby, and had mild hypoxemia, and that resolved over 24 hours. The next case, a 1.2 kilo baby born by normal delivery, in the first hour developed tachypnea. This was the first case I showed you actually, with the clear chest x-ray at birth, and then 12 hours later had the diffuse interstitial ground glass opacity on the chest x-ray. The saturation was 82%. There was no prolonged ruptured membranes and no maternal fever. What do you think this baby had? This first case that I showed you, this one. What did this baby have?
RDS?
Yeah, RDS, that's right. This is most likely respiratory distress syndrome. Of course, it could be a pneumonia, but most likely just respiratory distress syndrome. The third baby was 2.6 kilos, born by cesarean section for fetal distress. This was the last baby. The baby was floppy at birth, covered in thick meconium, tachypneic and grunting, hyperinflated with crackles. That was this baby. What do you think this baby had?
Meconium aspiration.
Yeah, good meconium aspiration, and the X-ray is classical for meconium aspiration, where you've got relatively hyperinflated lung fields and you've got this patchy opacity throughout the lungs. That's the meconium within the lungs, and then you've got areas of hyperinflation because the meconium blocks the airways, the bronchi and the bronchioles, and you get distal hyperinflation. So that's what a baby with severe meconium aspiration looks like. And the last baby, the last case, a 2.1 kilo baby born by normal delivery after prolonged ruptured membranes, 36 hours, with maternal fever, discolored liquor, grunting and tachypneic, developed at 6 hours of age, a temperature of 38.2. That was this baby here, this one here on the right. What do you think is most likely causing this?
The baby's got pneumonia.
Exactly, yeah. Most likely the baby's got pneumonia, and so congenital form of pneumonia, neonatal pneumonia, and the clues obviously are the fever and the prolonged ruptured membranes, the discolored liquor, and so the point about going through these is that firstly to teach you a bit about extended matching questions where you match up the scenario with the diagnosis, and when we get to the exams later in the year, you'll need to know about extended matching questions, but also the main reason to go through these cases is to demonstrate that a good understanding of the history can help us distinguish between the different types of respiratory distress syndrome or respiratory distress that occurs in neonates. And you don't have to have every detail of the history, but all the pertinent details that tell you whether the baby's preterm or not preterm, low birth weight or not low birth weight, whether there was prolonged ruptured membranes or not, whether the mother was well or febrile, whether the baby was febrile, etc. If you understand those basic things, if you get the history right, then you get a very good understanding of what the diagnosis is in terms of respiratory distress. The management of lung disease in preterm babies is mostly about the basics of what I mentioned before, oxygen, trying to titrate the oxygen saturation to somewhere between 88 and 95%, but not going higher, especially in a preterm baby. The use of CPAP can be helpful in babies with respiratory distress syndrome or respiratory distress of any sort. Maintaining the baby's nutrition, so using a nasogastric tube typically. Don't use intravenous fluids and so, unless necessary, or at least only use just a minimal amount of intravenous fluids to avoid fluid overloading the baby. Because when you give too much fluid, the fluid just goes onto the lungs and makes the baby's lungs wetter. If possible, in a baby who's not very sick, like who's only got mild or moderate respiratory distress, then keep the baby with the mother if at all possible. This is really important for the management of very low birth weight babies. It's increasingly recognised to be the way that all very low birth weight babies should be managed, not separated in a nursery, but to be kept with the mother. And that has major implications for a variety of things. One, whether the baby stays warm or gets hypothermic, whether the baby gets hypoglycemic, they'll be less likely to if they're with the mother, whether the baby gets septic. So if a baby is separated from its mother, then they're more likely to get infections with bacteria that are not similar to the healthy bacteria that a mother should transmit to their baby, but is more likely to be resistant bacteria or bacteria that are nosocomially acquired rather than acquired from the mother. Now this concept of the microbiome is very important in understanding about neonates. And I mean, as you probably know, when babies are born, they don't have any bacteria in their gastrointestinal tract, whereas in the first few weeks of life, babies have to acquire bacteria in their gastrointestinal tract, and they do so from their environment. And if their environment is a hospital ward and separated from their mother, then they often acquire more gram-negative bacteria and unhealthy bacteria. Whereas if they acquire the bacteria from their mother, they get more lactobacillus and they get more healthy bacteria that keeps their gastrointestinal tract healthy. So again, another reason why it's not good to separate the babies from the mothers. And that's why kangaroo mother care has become such an important part of managing moderately unwell preterm babies. CPAP is a useful mechanism for managing the respiratory distress syndrome. If babies are requiring more oxygen, then CPAP can be useful because it can be done without any additional oxygen or with much lower fraction of inspired oxygen. I won't go through all the aspects of CPAP now, but the important part of CPAP in preterm babies is that you can provide respiratory support with lower fraction of inspired oxygen. You don't need to use high concentrations of oxygen. So they're much less likely to get retinopathy of prematurity and less likely to get lung disease. So there are safe ways to give CPAP to preterm and very low birth weight babies that we could talk about. I wanted to talk a bit about nutrition in preterm babies. And to understand nutrition in preterm babies, we need to understand what happens during development. And the first and second trimester of a baby is all about organ development. So the development of the heart and the lungs and the gastrointestinal tract and the brain, most of the macroscopic development of those organs occurs by the end of the second trimester. And the late second and the third trimester is all about growth of those organs and accumulation of nutrients. So if a baby's born before the third trimester, then they won't have any nutrients accumulated. And that's why they have very low subcutaneous tissue. They have inadequate stores of glycogen in the liver, for example. They have very little fat. They may have a little bit of brown fat, but not very much fat stores. And that doesn't enable them to be able to withstand hypoglycemia or hypothermia. And so babies that are born preterm are deficient in all of those nutrients and all of those soft tissue stores that they could rely upon if they become unwell after they're born. So when babies are born preterm, they have increased nutritional demands, but at the same time, they have lower stocks of nutrients. So babies born preterm have rapid growth. They have to develop tissue quickly. They have, sometimes if they're in hospital, they have stresses of medical care. Even putting a drip in a preterm baby is some degree of stress on those babies, and it uses up more nutrition. They have poor temperature control for reasons I mentioned before, and because also their surface area to volume ratio is so large that they're losing heat constantly. So they're very prone to cold stress. And that uses up a lot of nutrition. They have very immature organ function. So they have their gastrointestinal tract is immature, their kidney function is immature, and they have very significant glucose instabilities because the glycogen, term babies and post-term babies have a lot of glycogen stores in their liver, and infants have glycogen stored in their liver, but preterm babies don't have that. And so they have nothing to draw upon if they don't get a constant regular glucose source. And that's why preterm babies are particularly prone to hypoglycemia. As I said, they have poor nutrient stores from being preterm in their liver and in their subcutaneous tissue particularly, and they have altered feeding patterns, don't they? They can't suck or swallow until they're at least 32 or 33 weeks. It's only after 34 weeks that a baby can reliably suck. So all these are risks of prematurity in all preterm babies, and we need to consider them when we're thinking about how to provide nutrition for preterm babies. When you're starting feeds on a preterm baby, you need to have some understanding of what breast milk contains. So breast milk has about, depending on the nutritional state of the mother, but about 70 kilocalories per 100 mils. All right, so for every 100 mils, the baby gets 70 kilocalories. And the energy goal for a preterm baby is about 130 to 150 kilocalories per kilogram per day. So therefore, the target volume has to be a bit more than that. It has to be about 185 kilocalories per kilogram per day, because that will give 130 kilocalories per kilogram per day. So when you're thinking about the target volume, the volume has to be higher than the kilocalories, because there's only 70 kilocalories per 100 mils. So we start these babies on day one on about 60 mils per kilogram per day. But by the time they're about a week or 10 days, then they should be up to at least 150 mils per kilogram per day. And then at about 2 weeks, you should try to get them to about 185 mils per kilo per day, because that will give them the kilocalories per kilogram per day that they need. So a 1.4 kilo baby, the feeding goal is at least 23 mils every 3 hours or 15 mils every 2 hours, depending on what how frequently you're feeding the babies. But if you're feeding every 3 hours, then 23 mils, and that's the goal that you would have, which is 185 mils per kilogram per day. Now, of course, you shouldn't try to achieve that in the first few days, because if you do, their immature gastrointestinal tract might not tolerate it very well. But you need to know what the goal is. Now, that doesn't apply if you're giving intravenous fluids. You should never give that much intravenous fluid to a preterm baby. It only applies if you're giving enteral feeding, and you grade up slowly over the first week and second week. So as I said, the day one requirements are 60 mils per kilogram per day, and that's 60 times 1.4, which is 84 mils over 24 hours, or 3.5 mils per hour, or 7 mils every 2 hours. So if you're feeding a 1.4 kilogram baby enterally by nasogastric tube, then it's 7 mils every 2 hours. And usually we start in the first few feeds with just 2 mils every 2 hours, and we increase as tolerated over the first 24 to 48 hours. And that way you can assess whether or not the baby's gastrointestinal tract is going to tolerate it. This is if a baby's less than 1.5 kilograms. If you're giving IV fluids because the baby is very unwell, then it's quite dangerous to give it just by an IV fluid bag and an open burette. Ideally, you'd use an infusion pump, because it's very hard to give just 2.5 mils per hour, which is all you need to give. 60 mils per kilogram per day, 3.5 mils an hour. That's a very small volume, and it's very hard to give through without an infusion pump. So it's much safer if you don't have infusion pumps to just start enteral feeding a very small amount and then titrate it up as you go along. When you are starting feeding in these babies, then you need to look for signs of feed intolerance. And that can be just when you do your ward round, you should assess to see whether there's any abdominal distension, or whether the baby's got vomiting, or whether the baby's got bilious residuals. That is, when you're aspirating a nasogastric tube, then if there's bile there, then that suggests that there's not so much good absorption of the milk. Don't aspirate the stomach too often. That's not a very good thing to do unless there's other signs of feed intolerance. If a baby's got a serious gastrointestinal tract intolerance, then they may have blood in their stools, or they may have other systemic features like apnea or bradycardia. These are things that they may have if they've got, if a preterm baby is feed intolerant or have developing necrotizing enterocolitis. This is an X-ray of a baby that does have a preterm baby, 1.3 kilos, who does have necrotizing enterocolitis. And I want you to just look at the gas pattern particularly. So some of these bowel loops are relatively normal, but you can see perhaps how thickened some of the bowel wall is. And most importantly, when you look here, how there's all these gas bubbles, and there's gas bubbles in the wall of the bowel. All right, you can see the gas bubbles here, and that's where you've got necrotizing enterocolitis with an anaerobic infection that's led to a severe infection of the bowels. So this is feed intolerance and necrotizing enterocolitis in a very preterm baby. And the treatment for that is to stop feeds and keep the baby nil orally for up to 10 days or even 2 weeks. Then you have to give intravenous fluids, and you have to give antibiotics that will cover bowel infections, so penicillin, gentamicin, and metronidazole, because often these are gram-negative or anaerobic infections. This is another baby that's got necrotizing enterocolitis, and you can see the gas within the bowel wall itself. You can see the thickened bowel wall and gas within the bowel wall, just here as well. So many areas of necrotizing enterocolitis. When we're feeding babies, then we need to know what their target weight gain should be, and to know how to assess their growth. And the expected weight gain differs for whether it's how big the baby is at birth. So if a baby is less than 2 kilos, then we would expect that they might grow somewhere between 15 and 30 grams per day. It doesn't have to be that much, but 15 grams per day is usually the minimum. And if they're more than 2 kilos, around about 20 grams a day is what's expected. So about 150 grams a week for a term baby or a baby over 2 kilos is what's expected. For a preterm baby, then a bit less than that, sometimes up to 100 grams a week is enough for a preterm baby. Their length should grow somewhere up to 1 centimetre per week, and their head circumference should grow somewhere between 0.5 and 1 centimetre per week. And so I think it's useful to have these criteria so that you can measure the weight gain that a baby's had and work out on a week-by-week basis whether it's satisfactory. We should use these growth charts for preterm infants who are corrected to term when they're corrected to term age, so that we know how fast a preterm baby should grow. It's a bit different to a baby that is at term. And so WHO has these preterm baby growth charts that we can use. And most babies we can achieve catch-up growth by about 2 years of age. So
Sudah pulang ke Sukabumi atau masih di Bandung? Ditanyain sama
most babies will most babies will achieve catch-up growth over the first year or two of life. So we can make corrections for gestational age up to the first year of life, and most babies will still get catch-up growth after that. When we initiate feeding in preterm babies, think also about their micronutrient needs. And breastfeeding has most of the micronutrients, but it's useful to give multivitamin supplements to preterm babies because they often are deficient in a variety of different vitamins, particularly vitamin E and vitamin D. As I said, they need vitamin D for their bone health. So I tend to give them just 1 ml per day of a multivitamin supplement. And then from 4 to 6 weeks of age, after they're stabilized, then they need iron supplementation, because when a baby's born preterm, it's the last trimester of pregnancy that most of the iron is transferred across the placenta. So if a baby's born at the end of the 2nd trimester or the start of the 3rd trimester, then they haven't had the same iron transfer across the placenta, and they'll become iron deficient, especially if we take blood from them, because every time you take blood from a preterm baby, you're taking iron from them as well. So they need iron supplementation after about 4 to 6 weeks of age. Don't give it too earlier than that, because if you give iron supplementation into the immature gut, then it's more likely that they'll get necrotizing enterocolitis, and also more likely that they'll get a gram-negative infection that like E. coli infection that feeds off the iron. So it's safe after 4 weeks of age, 4 to 6 weeks of age. Some babies who are preterm develop chronic lung disease, and it's useful to have an understanding about how to manage that. Most babies don't, but for those babies that do, whether they've developed chronic lung disease because of infection or because of their prematurity, their hyaline membrane disease, or other forms of inflammation or oxygen toxicity, then it's useful to know how to manage that. And chronic lung disease, by definition, is if a baby requires oxygen for more than 1 month, then they have chronic lung disease. And the treatment is really supportive care and trying to enable a baby to be healthy and to grow, because most commonly, if a baby's got moderate chronic lung disease, excuse me for a moment, yeah. If a baby has moderate chronic lung disease, then they're likely to grow out of it. They're likely to grow out of it after several years. As in, they'll grow more lung tissue as long as we keep their lungs free of infection, and we maintain their nutrition. So as I say, the management of chronic lung disease is all about supportive care. So giving enough oxygen that they need to just to achieve a saturation of 90%, not more than that, but a saturation of around 90%, improving their nutrition with breast milk and multivitamins, and later on good complementary feeding, avoiding where you can giving lots of antibiotics, because that alters the microbiome in the gastrointestinal tract, and it makes both the microbiome that we have in our gut and also in our lungs. Preterm babies often have a microbiome in their lungs. They have some bacteria colonizing their lungs, but it can make those bacteria very unhealthy and more resistant. So we should try to avoid antibiotics where we can and improve nutrition. We should avoid steroids when we can, but some babies with chronic lung disease need a course of steroids to improve their lung function, but don't give it for too long, only for 2 to 4 weeks, and then stop. And if we look after these babies, then lung growth can occur in the first 2 years of life and many years beyond. So I look after many babies with chronic lung disease that even after a few years of being on oxygen, they can then get off oxygen because their lungs grow and they become healthy, and they have not normal lung function, but they're no longer requiring oxygen, and they're growing normally, and they're healthy, and they're active children. So don't think that just because a baby's got an oxygen requirement for 1 month that they're always going to be sick and have lung disease. They just need, good basic care for the first year of life, and most babies can grow more lung tissue. I wanted to touch on retinopathy of prematurity. I've talked a bit about that before, but it's a very important complication of prematurity, and it's useful to know why it occurs. And it partly occurs because when a baby is born prematurely, they've got their blood vessels are very friable. They're very fragile blood vessels, both in their brain, so in the periventricular area of their brain, but also in their retina. And when babies are exposed to more oxygen, then that causes what we call neovascularization, which is the growth of new blood vessels, which are very friable. So this is a diagram of different stages of retinopathy of prematurity, where when you've got very advanced ROP, you have a lot of neovascularization, growth of very fragile capillaries on the retina. And those fragile capillaries leak plasma, and they can increase the intraocular pressure because they leak plasma into the retina, and they get and they can bleed, and then they can heal by fibrosis and scarring or distortion, and that can lead to distortion of the retina. And sometimes, if it's in the around the macula, then there can be blindness. If it's in the peripheral zone, then that can lead to retinal detachment. And so the most severe form of retinopathy of prematurity is where you've got a lot of neovascularization, you've got lots of plasma leak, you've got retinal hemorrhages, and then you get retinal detachment. And this can be a very serious problem, which you can avoid by reducing the exposure of these babies to oxygen, and also just general care of the preterm baby can reduce the risk of getting retinopathy of prematurity. The risk factors, the more preterm they are, the greater the risk of ROP. The more supplemental oxygen they get. Also, there's other risk factors we know about, like giving blood transfusions or having a severe anemia or severe RDS. They're not necessarily causative. They probably reflect how severely unwell these preterm babies are. If they need a blood transfusion or they got severe RDS, then they're just more at risk of ROP as well. And the complications, we've talked about the pathology. They get neovascularization and plasma leakage and bleeding and retinal detachment, but the complications can be either impaired vision or what we call amblyopia, which is a lazy eye or a squint, or glaucoma because there's so much pressure within in the subretinal region because of leakage of plasma, or and so that can lead to glaucoma, and sometimes retinal detachment leading to blindness. I was going to briefly talk about anemia of prematurity. I mentioned it before, but most very low birth weight and preterm babies are at risk of anemia. Remember I said because these babies, the iron is transferred across the placenta in the 3rd trimester, and also sometimes because of other reasons. One, we take blood from these babies when they're in the nursery, and there can be other reasons as well. And anemia can lead to a lot of complications, for example, apnea or desaturation or bradycardia or needing more oxygen or tachycardia. So when we are looking for signs of symptomatic anemia, we should be looking at those generalized signs of severe illness. We can prevent anemia somewhat by minimizing blood taking, by optimizing nutrition, by giving iron from 4 to 6 weeks of age, and that can minimize the amount of blood transfusions babies require. I think it's useful to have a sort of understanding of what the thresholds for giving blood transfusions for these babies should be. And so in the first 24 hours when babies are, if a very low birth weight baby is critically unwell and they've got a hemoglobin less than 10, then usually they'll need a blood transfusion if they're critically unwell. If they've got chronic lung disease, then later on as they grow, then usually I try to keep their hemoglobin above 8 grams per deciliter. And then if they're a stable patient and they're not acutely unwell, then if their hemoglobin's above 7, then that's usually good enough. So these are basic thresholds for transfusing these babies, but it's good to try to prevent severe anemia in these babies by minimizing blood taking and optimizing their nutrition and giving them iron supplementation. There's now quite good evidence about the thresholds for transfusion in preterm infants. There's been some studies done on this recently. So whereas before a lot of people transfused at much higher hemoglobins, it's now known that you can wait until their hemoglobin falls below 7 in most stable preterm babies to transfuse them, and do all the other things like give them iron and folic acid as well. The last thing I wanted to talk about was discharge criteria for preterm babies. And I think that this is important. I'll send this around, and I think this is very important because in the past, we often thought that when preterm babies reach a certain weight, they can then go home. Or even after they've been in hospital for 2 weeks or some fixed period of time, they can go home. But I think we need to be more sophisticated than that and try to understand what the right criteria are, discharge criteria for preterm babies. And I've put several different criteria here, and each of them apply. You have to, it's like a checklist, if you like. Unless the baby and the mother can tick off these criteria, then they're not really ready to go home. And so they've got to be, their weight has to be 1.8 kilos, breastfeeding, sucking well, and gaining weight. They need to be able to maintain their temperature between 36 and 37 degrees when clothed at room temperature. So when they've got their clothes on between 36 and 37 degrees, they can maintain their temperature. They need to have no apneas for 5 days and have oxygen saturations more than 90% on air, unless they're going home on supplemental oxygen, but basically having adequate saturations with no apnea. We need to teach the parents how to bathe the baby, how to care for the infant, and if they're high-risk babies, how to do CPR and other aspects of preterm baby care. I think the parents must be prepared psychologically and mentally for the care of their babies and know how to look after them and who to communicate with. And we should assess their social risks as well, whether or not the environment is safe for them to go home. The babies should have had all their first dose of all their vaccines, and they should have a a complete examination, including looking for all the complications of prematurity. And then you need to arrange follow-up. And usually follow-up you should do every week for the first month or two at least, just to check their growth and see that their baby's growing well and the nutrition's okay, and give them their vaccines as they need. There's good evidence now that if you, it's only safe to discharge babies under 1.5 kilos if you've got a good community follow-up. And there's some, in some countries in Asia and South America, there's been some good follow-up studies done where they've discharged babies under 1.8 kilos, but they have a nurse going out to the home to visit the mothers. And I think if you don't have that, most places don't have that facility, then you've got to have some discharge criteria. And I think that these, instead of just saying after 10 days or 2 weeks, the baby can go home, you need to have criteria to work towards while the baby's in hospital. It helps to understand all the things, to explain to the parents what they have to learn and do before they take their baby home, I think, if you have these criteria. We should at least review babies monthly, very low birth weight babies, even more often in the first month or two. We're reviewing their nutrition and growth. We're reviewing their neurodevelopment. We're reviewing them for infections and giving them vaccines. I think these are all the risks that preterm and very low birth weight babies have in the first year or two of life. I noticed particularly when the preterm babies in Goroka were first starting to survive, those that were born under 1.5 kilos, we had a lot of babies coming back with infections or with severe malnutrition. And unless you put in a program to monitor these babies' growth charts every month and look at their weight and their length and their head circumference, and to optimize the mother's nutrition and give them multivitamins and iron and zinc, and check their development and look out for infections, they're more prone to pneumonia and bronchiolitis. Unless you have a program that puts all those things in place, a follow-up program for very low birth weight babies, then that you'll have a lot of morbidity in the first year or two of life, and unfortunately a lot of late mortality. So if you have a program like this where you're looking after very low birth weight babies, then you can get good survival and good quality of survival rates for these very low birth weight babies. So that's all I was wanting to discuss today, to give you the basics of the management of preterm and very low birth weight babies, and I'm happy to answer any questions that you might have.